Hello everyone, my name is Pegah Afra and my talk is anti-epileptic drugs. Thank you very much for inviting me to give this talk as a part of MSK-NYP Neuroscience lecture series. Here is my disclosure slide. So here are my objectives. The first objective is to introduce the fact that the term anti-epileptic drugs or AEDs have been replaced by the term anti-seizure medications or ASMs. And as you know, we have lots of anti-seizure medications and there is no way that I can cover them in 1 hour. So I use the following strategy to cover a helpful chunk of information. First, I will do a case-based review of ASMs. These will be very clinical around treatments of first-time seizure, acute symptomatic seizure, and remote symptomatic seizure. Then I review 2 of the most commonly used classes of anti-seizure medications in adults, the sodium channel blockers and SV2A vesicle blockers. So here is case 0. A 30-year-old right-handed male is brought to the emergency room after initial witnessed generalized tonic-clonic seizure. The question is treat or not to treat. And the answer will depend on the risk of recurrence. We classify seizures based on the recurrence risk. Low recurrence risk here are in blue color, and these are provoked seizures and acute symptomatic seizures. The term provoked seizure and acute symptomatic seizure are used many times interchangeably in the literature. And I think it is important to differentiate the two because in the provoked seizure, the insult is systemic and the brain gets a kick. While in acute symptomatic seizures, the insult is primarily a CNS insult. So examples of provoked seizures are seizures occurring within 24 hours of a metabolic abnormality like acute hypoglycemia, acute hyponatremia, or within 7 days of drug overdose, ethanol consumption, or binge drinking and recreational drug use. Acute symptomatic seizures occur within 7 days of a primary CNS insult like stroke, intracranial hemorrhage, subdural hematoma, trauma, AVM, etc. Now, high recurrence risk seizures happen in unprovoked seizures and remote symptomatic seizures, which are seizures that happen 7 days after the CNS insult. And high recurrence risk seizures are in purple color in this slide and the upcoming ones. Information in this slide is taken from Hersdorfer et al. And in this paper, they used the term provoked seizures and acute symptomatic seizures interchangeably. Regardless, the acute symptomatic seizures are 8.9 times more likely to cause death within 30 days of presentations. Therefore, they have higher acute morbidity and mortality associated with them, which is what dictates the need for anti-seizure medication treatment in the acute phase. However, acute symptomatic seizures are 80% less likely to result in subsequent unprovoked seizures when they are compared to individuals with a first unprovoked seizure. Therefore, they may not be a risk category that requires chronic or long-term anti-seizure medication treatment. Now, when to treat first-time seizures? First, determine patient had an epileptic seizure. Second, assess recurrence risk. Remember, less than 50% of patients with a first-time seizure will have a second seizure. And most importantly, provoked seizures and acute symptomatic seizures do not confer long-term risk for subsequent seizures. Increased recurrence risk of 21 to 45%. Please note there are some higher numbers in the literature, but I used what is in American Academy of Neurology practice recommendations. So in remote symptomatic seizures, which are seizures with abnormal imaging and structural lesion, seizures with abnormal epileptiform activity in the EEG, and nocturnal seizures, we have increased recurrence risk of 21 to 45%. And one important thing is that the immediate anti-seizure medication therapy delays time to the second seizure, but will not influence the long-term remission, or in other words, it does not change diagnosis of epilepsy. So a practical way is basically what American Academy of Neurology and American Epilepsy Society recommend, and that is treat a patient if they have 2 seizures more than 24 hours apart, or if they have 1 seizure and abnormal MRI, or 1 seizure and abnormal EEG. So here is case 0 continued. Now the patient comes to outpatient follow-up. So 30 years old right-handed man with no significant past medical history was taken to the emergency room by ambulance after having a single witness generalized tonic-clonic seizure lasting 1 minute with tongue biting and urinary incontinence in his workplace. EEG done immediately after arrival in the ER showed diffuse slowing and right temporal shock waves. MRI with and without contrast was normal. Lumbar puncture was negative. He was started on Keppra 500 twice a day and was referred in follow-up to your clinic. So already with this minimal provided history, he qualifies to continue on anti-seizure medication. Why? Because although he has had only 1 generalized tonic-clonic seizure, he has had an abnormal EEG with epileptiform activity in the form of right temporal shock waves. Here is the rest of the story. On questioning, he reports that he started to have déjà vus in his college years. They usually occur once or twice per month and last 20 to 30 seconds. He sometimes feels tired after them, but so far have considered these normal or due to stress. He really needs to get off this medicine called Keppra or levetiracetam, which they gave him in the emergency room. As he has been increasingly irritated since discharge from the ER, his co-workers find him snapping out. You inform him that with the provided history, he qualifies with diagnosis of focal aware seizures with secondary generalization and needs to be on anti-seizure medication regardless of if his EEG was normal or abnormal. So one can say the conclusion from this slide is that number 1, patient has partial onset epilepsy. Number 2, he needs to be on a long-term medication. It doesn't need to be levetiracetam. It can be any medicine that he tolerates. Now, this takes us to the next slide. Which anti-seizure medications to use after first-time seizure? The first question is, should we use first generation or second generation medications? Where first generation's ASMs are things like barbiturates, phenytoin, carbamazepine, etosuximide, valproic acid, and benzodiazepines. While second generation ASMs are everything else approved in 1989 and after, and we have more than 18 of them. What is the difference? Is the efficacy any different? No, second generation's ASMs are not more efficacious than first generation ASMs, with one exception, and that is cenobamate, which we'll discuss later. It's the only medicine that is more efficacious. How about tolerability? Yes, second generation ASMs are better tolerated. How about safety? Overall, second generation ASMs are less likely to cause pharmacokinetic interactions, and therefore they are safer. Which of the 18 plus ASMs to choose from? Well, here it comes practicing the art of medicine. One can choose any of these medications and there will be no wrong answers. But one has to choose one that has the least cognitive side effects and is approved by patients' insurance. Many epileptologists prefer to start with what I call the 3Ls. Levetiracetam, because it's renally cleared, it has no drug interaction. But the caveat is that it's a divorce pill, makes people irritated, agitated, nasty, and gives them what we call Keppra moments. The second L is lamotrigine, is a mood stabilizer. It's the happy pill, but the caveat is that it can cause a rash that rarely can turn into Stevens-Johnson syndrome. The last L is the lacosamide, which is mood neutral, has no drug interactions, but the caveat is that it may prolong the PR interval. And now let's switch the focus to when to discontinue seizure medications for provoked seizures. Please note, I did not make up any of the cases. They are variations of what me and my colleagues see as an epileptologist. This case is a variation of a real case that presented to Dr. Doria's clinic just a couple of months ago. A 35-year-old man comes to your outpatient clinic. He is healthy and has no significant past medical history except 2 convulsive seizures when he was 20 and 22 years old in setting of excessive drinking in college. After the second seizure, he was started on levetiracetam 750 milligram orally twice a day and has been taking it ever since. He has had an MRI and multiple EEGs, and all were done after he was started on levetiracetam, and they all have been normal. He's not drinking anymore and wants to come off his medication. The story seems like a provoked seizure while binge drinking. You repeat MRI, which is normal. You do a sleep-deprived EEG, which is also normal. After counseling him to observe seizure precaution, you gave him a taper schedule. Week 1, levetiracetam 500 twice a day. Week 2, levetiracetam 250 twice a day. Week 3, stop. You scheduled him for an ambulatory EEG on week 4 and then follow-up. He comes back to your clinic after his ambulatory EEG and reports feeling really good and free of levetiracetam. However, the ambulatory EEG reports shows a rather frequent 3 to 4 Hz generalized spike in slow waves and polyspike in slow waves during sleep and more than wakefulness. This means he qualifies for electrographic criteria of juvenile myoclonic epilepsy. He will qualify to diagnose him clinically with JME if he gives history of morning myoclonic jerks, or if he has had a generalized tonic-clonic seizure. You inform him of the EEG showing that his original seizures were a result of unmasking of underlying epilepsy in setting of drinking and therefore restart his levetiracetam. So the point of this case is to always consider unmasking of epilepsy in differential diagnosis of provoked or acute symptomatic seizures. Now, when do acute symptomatic seizures become remote symptomatic seizures? This means they change risk and they change recurrence risk. So if you remember in the previous slide, we said acute symptomatic seizures have low recurrence risk, while remote symptomatic seizures, which are seizure in presence of abnormal MRI, have a high recurrence risk. First of all, why is that? It is because it takes a while for the brain to learn how to seize. If there is already abnormal lesion, it means the brain has had prep time to learn to produce seizures and therefore has epilepsy, condition of recurrent unprovoked seizures. If acute brain insult and the seizure present at approximately the same time, it means the brain has not had time to learn how to seize. The seizure is just provoked by insult. Now about the question of when do acute symptomatic seizures become remote symptomatic seizures? If a second seizure occurs after 7 days of acute brain insult, then the acute symptomatic seizure becomes remote symptomatic seizure and will require long-term anti-seizure medications. The only exception is if you have successful surgical intervention, like complete removal of the CNS insult, being AVM, subdural hematoma, tumor, within the 7 day, but the patient experiences a second seizures after 24 hours of the first one, but within 7 days, but after the surgery. In such a case, he will still be diagnosed with remote symptomatic seizure and will require long-term anti-seizure medications. And we'll see example of these in the upcoming slides. So here we have a 75-year-old lady presents to the emergency room with acute onset of expressive aphasia. MRI shows left temporal meningioma, no abnormal signal in the cortex. EEG shows non-convulsive status epilepticus from left temporal area. She's diagnosed with acute symptomatic seizure and is treated with IV lorazepam and IV levetiracetam and started on Keppra or levetiracetam, 750 milligram orally twice a day. On day 3 after presentation, she undergoes a successful resection of meningioma. On day 5, while talking with her daughter who is visiting, she has another episode of inability to talk. She's given 2 milligrams of lorazepam and her levetiracetam is increased to 1,000 twice a day. MRI shows expected postoperative changes and some abnormal signal in the cortex of left temporal lobe. EEG after return to baseline shows no seizures and left temporal bridge rhythm. This latter seizure puts patient in remote symptomatic seizure category, and therefore she will need chronic anti-seizure medications because it happened less than 7 days, but after the surgical intervention. When acute symptomatic seizures become remote symptomatic seizures. Here is another one. 76-year-old man was brought to the emergency room with acute onset of left-sided weakness. MRI showed a hemorrhagic stroke in right hemisphere. Later that day, nurses noted abnormal involuntary movements in this weak left side. 30-minute EEG showed 5 focal left frontocentral seizures of 20 seconds duration. Patient was diagnosed with focal non-convulsive status epilepticus, was given 2 milligrams of Ativan and loaded with levetiracetam. Continuous EEG did not show any further seizures. Multiple seizures in 24 hours are counted as one acute symptomatic seizures. We treat these because of high morbidity and mortality in acute setting. On day 9, he was discharged to rehab, and during transfer from inpatient to rehab, he missed a single dose of his levetiracetam. He had a brief 15-second episode of left-sided shaking. He presents to your clinic 6 months after that acute hospitalization, and only seizure he has had after discharge was that 15-second episode upon admission to rehab. Can he come off of his levetiracetam? The answer is no, because with that brief 15-second seizure, he's now in category of remote symptomatic seizures and will require long-term anti-seizure medications. This is because it proves that the brain has learned how to seize and is capable of producing seizures. If we remove the medication, it is the proof that he will have a seizure. That is why he now changes category and will require chronic anti-seizure medications. Now let's change gears and look at some anti-seizure medications. The most commonly used anti-seizure medication class in adults are sodium channel blockers. As you see, we have first generation ones like phenytoin and carbamazepine, and we have second generation ones like oxcarbazepine, eslicarbazepine, lamotrigine, lacosamide, and cenobamate. And you can see that there is 2 major classes, fast sodium channel blockers and slow sodium channel blockers. The sodium channel has a resting state, and once it's depolarized, it goes into the open state. Once in the open state, it can undergo fast inactivation with a ball and chain mechanism, which is where the sodium channel blockers work within milliseconds, followed by repolarization into resting state, where the channel can become available for future depolarization. The slow sodium channel blockers inactivate sodium channel by conformational change. They are slower, which means inactivation does not happen in milliseconds, but it happens in seconds and beyond. The conformational change renders the sodium channel not available for further depolarization. These will be medications like lacosamide and cenobamate. Also, older medications which are considered fast sodium channel blockers, like dilantin, oxcarbazepine, and eslicarbazepine. It is less clear if they are only fast sodium channel blockers or they have some slow channel blocking properties. When it comes to the mechanism of action of the cenobamate, it works like the other sodium channel blockers on the voltage-gated sodium channels in the presynaptic membrane. But it also works on the postsynaptic membrane and is an allosteric modulator of GABA-A receptor. Therefore, it decreases activation in presynaptic membrane and it increases inhibition in postsynaptic membrane. All these things are written about it, but it is still said that the precise mechanism of action is unknown. So cenobamate was FDA approved in November 2019 for indication of treating of partial onset seizures in adults 18 years of age or older. The highlights from the clinical trials are high level of efficacy. There is an unprecedented seizure-free rates of up to 28% and a reduction in monthly seizure frequency of up to 55%. This makes cenobamate the most efficacious anti-seizure medication ever approved. Now, on the side effect side of things, there were 3 cases of DRESS, which included 1 fatality. In the first 953 patients exposed to high starting dosages and or weekly up titration. As a result of that, they changed the schedule, up titration schedule of cenobamate. Nowadays, we start very low at 12.5 milligrams per day, and there is bi-weekly titration. After this, there has been no further DRESS cases in 1,339 patients in the open label safety trials. Here is case 4. A 42 years old right-handed man with no risk factors for epilepsy have been experiencing intermittent aura of anxiety and epigastric rising warm sensation lasting 1 minute for the past 2 years. He had his first secondary generalized tonic-clonic seizure after one of these auras 3 to 4 days ago. In the emergency room, he was diagnosed with focal aware seizures with secondary generalization and was started on an oral medication. 3 days after he started the medication, he feels nauseated, he has double vision, and has feeling of being off balance. Now, which sodium channel blocker do you guess he was started on, given these 3 side effects? The answer is any of the sodium channel blockers, because regardless of which of the sodium channel blockers you prescribe, they all have a class side effect. The class side effect includes double vision, blurry vision, which can present itself in the form of nystagmus on neuro exam, dizziness and vertigo, which can cause ataxia on neuro exam, nausea, vomiting, worsening headaches. These are all sodium channel blocking side effects each and every medication in this sodium channel blocking group on the right side of the slide can cause these side effects. They are additive and dose dependent. What does this mean? It means if I add lacosamide to carbamazepine, patient is more likely to experience these side effects. They don't necessarily belong to lacosamide or carbamazepine. They are the result of adding the two on each other. There's two ways to tackle this problem. Either I should not add lacosamide to carbamazepine, or if carbamazepine has already been not effective for the patient, which is why I am adding lacosamide, I should taper the carbamazepine dosage down. Here is another one. A 56-year-old man with history of first-degree heart block presented with 2 seizures in the past month. He was started on an ASM in the emergency room that he's tolerating very well but cannot remember the name. His cardiologist calls you to let you know that in his EKG done today, he has a second-degree heart block. Cardiologist is wondering if the ASM they started in your emergency room could have been the cause. What do you guess the ASM is before looking in the medical records? Well, the answer is lacosamide. Why? Because the ASM converted first-degree heart block to second-degree heart block. Therefore, if any ASM causes this, it should be working on the PR interval. And therefore, the most likely answer is lacosamide. If we look at the cardiovascular side effect of sodium channel blockers, there are some disturbing data about them in the literature. The one that bothers me the most is that the enzyme-inducing sodium channel blockers increase a hazard of cardiovascular disease in a dose-dependent fashion. And this reaches clinical significance after 10 years of exposure. And this is not a class effect, but it is more an enzyme induction effect. What does this mean? It means that it not only affects enzyme-inducing sodium channel blockers like phenytoin, carbamazepine, oxcarbamazepine, and eslicarbazepine, but also affects any other anti-seizure medication that has enzyme-inducing properties, including topiramate, rufinamide, and primidone. The other effect of sodium channel blockers on the heart is by blocking the sodium channels in the heart or the conduction pathway of the heart. In this slide, I just discussed the ones that have undergone cardiovascular electrophysiological studies or they have been in vitro. And in the next slide, I discuss this effect by clinical experience, which will be more relevant and in vivo. When it comes to cardiovascular electrophysiological studies, we know dilantin and lamotrigine are class 1B antiarrhythmics. This means that they shorten the QT interval and have no effect on QRS length, while carbamazepine is class 1A with some 1B effect, which means it will widen QRS complex and prolong the QTC interval. Before we go to the next slide, which summarizes cardiovascular side effects in vivo, we should also consider the effects of solvents. This one applies the most to phenytoin IV, which is delivered in propylene glycol, which causes hypotension and bradycardia. IV phosphenitoin, which is the phosphate ester of phenytoin and water soluble, which means it does not need propylene glycol as a vehicle, only causes hypotension and bradycardia in rapid infusion rates. So it's mainly cardiovascular side effect of phenytoin itself and not the added hypotension bradycardia by the solvent propylene glycol, which makes it more severe. So by their sodium channel blocking properties, they can have some depressant effect over the heart and conduction pathways. And these are the ones that have been reported, or in another words, seen in vivo in patients. The one that increases the PR interval and causes first-degree heart block is lacosamide. The ones that have been reported to cause second and third-degree heart block are carbamazepine and lacosamide. Lacosamide has been reported to cause atrial fibrillation and atrial flutter. Um, Dilantin and lacosamide have caused bradycardia, cardiac arrest, and death. Lamotrigine causes widening of QRS complex, while cenobamate causes shortening of the QT interval, and therefore it is contraindicated in familial short QT syndrome. In general, in addition to the above, I personally avoid using sodium channel blockers in patients with high cardiovascular risk factors like hyperlipidemia and smoking, Brugada syndrome, which is a sodium channelopathy of the heart and predisposes people to syncope and cardiac arrhythmias, patients with left bundle branch block, or patients with right bundle branch block and left anterior or a left posterior fascicular block. In general, one can say if the patient has a healthy heart, sodium channel blockers are generally safe and well tolerated in oral formulation. However, in cardiovascular disease or presence of cardiovascular risk factors, including everything I said, as well as arrhythmias and other cardiovascular diseases, we have to use sodium channel blockers with cautions, check EKG and consult cardiology in doubt. I personally avoid using sodium channel blockers in anyone that has an arrhythmia. And I am very, very cautious using them in patients with any form of cardiovascular disease or risk. Here is the next case. A 47-year-old man with past medical history of lesional epilepsy secondary to right MCA stroke was recently switched from levetiracetam due to worsening depression to oxcarbazepine. Although his depression is much better and seizures are well controlled, but he has not been feeling well. He's having lots of dizziness, tiredness, and sense of instability. He was taken to the ER and his sodium was 124. What other sodium channel drugs should be avoided? So this is a case of drug-induced hyponatremia, and it occurs when sodium channels in the kidneys tubules are blocked and sodium cannot be reabsorbed and pours out of the body. The dibenzazepine carboxamides, which are carbamazepine and its extended release formulations, oxcarbazepine and its extended release formulation, and eslicarbazepines are the ones that cause the sodium channel blocking in the kidney tubules. You can see in this image how structurally similar these three are, and this is something to consider when it comes to their allergic reactions too. How about skin reactions? I always like to show this image because it shows what we don't see anymore because of redundancy and improvement in anti-seizure medications. This is purple glove syndrome and occurs due to extravasation of IV dilantin from propylene glycol, and with coming of IV phosphatidone, this is not seen anymore. So how about hypersensitivity and skin reactions? Here is an example. A 24-year-old right-handed Asian man was recently diagnosed with epilepsy and started on oxcarbazepine. He developed a severe allergic rash. Which of the other ASMs are contraindicated in his case? Well, contraindications will be oxcarbazepine XR and eslicarbazepine XR because of almost identical chemical structure. Precautions will be carbamazepine and carbamazepine XR because of similar chemical structure. One thing to consider is that this patient is Asian and they have a higher incidence of severe cutaneous reactions with ASMs, including Stevens-Johnson syndrome and toxic epidermal necrolysis. I recommend either avoiding these medications in patients of Han-Chinese ancestry or testing the HLA-B1502. The most common meds to avoid is carbamazepine, dilantin, and lamotrigine. In my opinion, oxcarbazepine, eslicarbazepine, and cenobamate need to be added. I say this because in recent clinical trials, people of Asian ancestry have been HLA type, and if they were positive for HLA-1502, they excluded. Therefore, we did not have any HLA-1502 positive patients in eslicarbazepine trials, for example. In cenobamate, once the 3 cases of Dravet syndrome raised their head in the clinical trial, the company changed the titration and made it extremely slow. I say extremely slow because if you compare lamotrigine titration to cenobamate titration, the cenobamate is much slower than lamotrigine. In both drugs, you can get to goal dose of 400 milligrams per day. With lamotrigine green pack, this takes 9 weeks. With cenobamate, this takes 11 weeks to only get to 200 milligrams once per day. While in lamotrigine, after 9 weeks, you got to 200 twice a day, which is equal to 400 milligrams per day. If you want to get to 400 milligrams per day with cenobamate, you can go up by 50 milligrams every 2 weeks. It means week 11 and 12, you're on 200 once daily. Week 13 and 14, you get to 250 once daily. Week 15 and 16, you get to 300 once daily. And week 17 and 18, you get to 350 milligrams once daily. And finally, on week 19 and thereafter, you get to 400 milligrams once daily. So the path that takes 9 weeks for lamotrigine will take 19 weeks with cenobamate. Therefore, the titration is much slower. Here is a visual presentation of how to increase the cenobamate every 2 weeks. Maximum recommended dosage is 400 milligrams once per day, and special populations are patients with renal impairment. We have to use with caution in mild to moderate renal impairment, but is not recommended for use in end-stage renal disease or hemodialysis. For a special population of hepatic impairment, we have to use with caution in mild to moderate hepatic impairment, but it is not recommended to use in severe hepatic impairment. Here is another case. A 28-year-old Italian woman, patient of yours who has been seizure-free for more than 3 years, calls you from the Caribbean. She angrily tells you on the phone that while in her honeymoon, she had a grand mal seizure. Why now? Can you explain? She has been taking her medications religiously. Can you guess what happened? Well, she started oral contraceptive during her honeymoon. Estrogen component of oral contraceptives chew up lamotrigine, and lamotrigine chews up estrogen component of oral contraceptives. So in worst case scenario, patient can be seizing and pregnant. It is okay to use progestin-containing oral contraceptives or hormone-impregnated intrauterine devices like Mirena or Kylena IUD with lamotrigine, because the hormones are mainly released locally in the uterus. So if we look at the effects of sodium channel blockers on oral contraceptives, we can see that all of them chew estrogen and progesterone, and the only 2 exceptions are lamotrigine and lacosamide. Lamotrigine only chews estrogen and has no effect on progesterone, and lacosamide does not have any effect on estrogen or progesterone. On the other hand, when we look at how oral contraceptives affect sodium channel blockers, the only one affected is lamotrigine, and that is because estrogen chews lamotrigine. What does this mean? This means that oral contraceptives cannot be used as contraceptive measures, but they can be used for menstrual controls with non-lamotrigine sodium channel blockers. When it comes to lamotrigine, because estrogen decreases lamotrigine concentration, we can only use progestin-only oral contraceptives. What about warfarin? It should not be used with phenytoin and carbamazepine. When it comes to oxcarbazepine and eslicarbazepine, there are clinically non-significant decreases in S and R enantiomers of warfarin, but no change in total INR. This is basically means biology is approximate and life is relative. I think there is more and more newer anticoagulants being released, and the best way is when we start anticoagulants on patients with epilepsy, or we start anti-seizure medication on patients on anticoagulants, we should always check micromedics or another source for drug-drug interactions. Cenobamate has drug-drug interactions with other anti-seizure medications. Cenobamate activates some substrates of CYP while inhibits others, and therefore drug interactions are complex and need to be checked before starting cenobamate. For example, cenobamate decreases plasma concentration of lamotrigine and carbamazepine, and it increases plasma concentration of phenytoin, phenobarbital, and desmethylclobazam. When it comes to non-anti-seizure medications, cenobamate decreases CYP, 2B6 substrate, and 3A4 substrate and oral contraceptives, and it increases CYP2C19 substrate. As you see, it's very complex. One needs to check for drug-drug interactions on patients with polypharmacy before starting cenobamate. Here is another case. A 34-year-old left-handed woman, mother of 3, status post bilateral tubal ligation with past medical history of non-temporal lobe epilepsy on lacosamide 200 mg orally twice a day. She takes her medications like a clock and never misses a dose. She has failed in the past dilantin, carbamazepine, and oxcarbazepine, and lamotrigine. Of course, this patient is an excellent candidate for pre-surgical evaluation, but this is not what my talk is about today. So she has been generalized tonic-clonic seizures free for the past 3 years, but started having orals for the past 2 months with frequency of 2 to 3 per week. One of these ended in a breakthrough secondary generalized tonic-clonic seizure. She was taken to the emergency room where her lacosamide level was 10.1. She was loaded with levetiracetam and discharged on 750 mg twice a day to take in addition to her lacosamide 200 mg twice a day. She comes today to the clinic and let you know that since her last seizure, she has not been back to her normal. She keeps snapping at her husband and children and is very irritated at work. When she comes home, she's anxious and keeps crying. What is so strange is that she has not even had a single oral since her grand mal seizure. So we can conclude the Keppra is efficacious for her. It works because it makes her seizure-free and aura-free, but she's not tolerating it at all. So if you look at levetiracetam, it is a wonder drug. It's a renally clear drug, minimal drug-drug interaction. Its main problem is causing what we call Keppra moments, and extremely rarely it can cause thrombocytopenia that 100% of times is reversible. So if we could just get rid of the Keppra moment side effect of levetiracetam, what could be better? We would have a wonder drug. This is why breveracetam was developed, but it comes with 2 caveats. One, it has so far only one known mechanism of action, and that is that it blocks SV2A vesicles And while Keppra also works on AMPA receptors, which may be what underlies the divorce pill side effects, and it also blocks calcium channels. Having multiple mechanisms of actions is like insurance for epileptologists. If one mechanism of action does not work, the other may be there to provide some protection. The second caveat is that brivaracetam is not only renally cleared, it has some hepatic pathway and some extrahepatic hydrolysis. So should the patient in our case be started on brivaracetam? Well, short answer is yes. But the long answer is first do no harm. Make sure patient's insurance covers it. If not, if the insurance doesn't cover it, it is not the end of the world. All anti-seizure medications have similar efficacy. Use something that is affordable by the patient. Use side effect profile and patient comorbidities and concomitant medications as the guide of which medication to choose. I personally think cognitive side effects are one of the most important considerations as people need to live their lives in a wakeful state, be successful parents, successful students, and so on. If you need to start brivaracetam, dose escalation is not necessary. We usually start at 50 milligrams twice a day, which is considered a low therapeutic dose. We can go up on the next step to 100 milligrams twice a day directly, or we can go up 75 twice a day for 1 week and then go up to 100 twice a day. Brivaracetam can be taken with or without food, and tablets should be swallowed and not chewed or crushed. If we look at the formulation of brivaracetam, the oral tablets come in 10, 25, 50, 75, and 100 milligrams. It has a liquid formulation, which is with concentration of 10 milligrams per ml in a 300 ml bottle. And it has injection with concentration of 50 milligrams per ml in one vial, which is the same, with concentration of 10 milligrams per ml in the vial, and the vial contains 5 ml, which is 50 milligrams. One thing that is important to remember about the vial is that in vial is just 150 milligram or equivalent of 150 milligram tablet. So if you want to give someone a full dose, you have to inject them with 2 vials to give them 200 milligram dosage. Brivaracetam has some common side effects that are dose dependent. These are somnolence and sedation. It has other side effects that are not dose dependent. These include nausea, vomiting, constipation, dizziness, fatigue, ataxia, and disturbance in gait and coordination, and psychiatric adverse reaction. Irritability is much less common than Keppra, and in randomized controlled trials, it was seen in 3% of treated patients and 1% of placebo, which is the same as every other anti-seizure medication, but Keppra had a lot higher irritability side effects. Here is our last case, case 10. A 45-year-old right-handed gentleman with intractable partial onset epilepsy, status post-left temporal lobectomy with 1 to 3 partial seizures per month. He has been on carbamazepine and continues to have breakthrough seizures. He has failed every other medication known to any epileptologist and has heard that brivaracetam has been recently approved and wants to try it. You discuss with him that although he had good response to levetiracetam, he had severe irritability on it. You add brivaracetam to his carbamazepine and titrate to 100 milligrams orally twice a day. He goes into a drug holiday, i.e. he has no further seizures seizures, but today he comes to clinic with his father because he's extremely sleepy and dad is afraid for him to come alone. His carbamazepine level is at 10.5 to 11.5 range, which is what it has been for years. So the question is, what happens? What happened to this gentleman is in green ink. And it is because of the effect of brivaracetam in other anti-seizure medications. Brivaracetam does not change total carbamazepine levels, which is why his levels was the same as what he has had for years. But brivaracetam increases carbamazepine epoxy concentration by 198% when the patient is taking 100 milligram of brivaracetam twice a day. And this means brivaracetam is a reversible inhibitor of epoxide hydroxylase. Therefore, correct action in this patient is to reduce dosage of carbamazepine, although the total serum levels were unchanged. Brivaracetam also increases plasma concentration of dilantin by 20%. Brivaracetam should not be used with levetiracetam. When it comes to effects of other anti-seizure medications on brivaracetam, enzyme inducers like carbamazepine, dilantin, and phenobarbital decrease plasma concentration of brivaracetam. What about drug interaction with non-AEDs? Rifampin decreases brivaracetam plasma levels by 45%. If patient on rifampin, we have to increase brivaracetam dosage by 100%. Oral contraceptives were studied at supratherapeutic dosages and reported to be not clinically significant effect of brivaracetam on oral contraceptives. However, oral contraceptives have higher failure rates when used for contraception in epilepsy, and therefore they can be used for non-contraceptive reasons like menstrual control, but not for contraception itself. When it comes to patients with hepatic impairment for all stages, we start lower at 25 milligram twice a day, and maximal recommended dose is 75 milligram twice a day. In renal impairment, dose adjustment is not needed, but there is no data on patients with end-stage renal disease on hemodialysis, and therefore brivaracetam should not be used in this population. So my talk lacks the slides in the interest of time for broad spectrum versus narrow spectrum anti-seizure medications. Broad spectrum anti-seizure medications can be used for all seizure types of generalized onset and partial onset, while narrow spectrum ASMs can be used only on partial onset anti-seizure medications. Examples of broad spectrum anti-seizure medications are valproic acid or Depakote, levetiracetam, lamotrigine, Topamax, zonisamide, Fycompa or Prampanil, and clobazam. Sometimes when all medications fail, we use Vimpat. Outside of these, the rest of the commonly used ASMs are narrow spectrum and can be used only for patients with partial onset epilepsy. The second point is that all ASMs come with black box warning of suicidal ideation by the FDA. Therefore, we have to counsel patients about depression and suicidality when we initially prescribe these, and then screen for depression and suicidal ideation in each and every clinic visit. In conclusion, there is an ever-growing pool of anti-seizure medications with wide pharmacodynamic and pharmacokinetic effects. With advances in critical care neurology, there is a host of new patients that end up in anti-seizure medications, and when in doubt, we should consult epilepsy. This is my last slide. Thank you very much for your attention.